Okay, welcome everybody. We have the honor of having Dr. Joey Miles here. He's going to go over a presentation on HRV, and without further ado, let's get right to the program. Go ahead, Dr. Joey.
Okay, Rob, thanks for having me. Thanks for putting this together. It's a it's a big subject, so I did my best to try and compile a good bit of examples of things that we've been seeing. I wanted to cover some context, why HRV can be valuable to us as upper cervical chiropractors, and also just ask everybody to give me a little leeway here because I've got a little bit of a groundwork I want to lay down before I get into some of the results. Rob, is it okay for me to hit this orange button and get
Yes,
this
you
out
go
of the
right
way now?
ahead because I didn't see it. Oh, I hit mine, so you go right ahead.
Okay, cool.
And you might want to
All right.
actually maximize your screen.
Okay. On my end, it's maximized, I believe.
Okay, you're fine then. Go right ahead with what you're doing.
Okay. So just real quick on, I don't have my email anywhere else, but of course, most everybody on here heard of this from Facebook. So if people have questions beyond the presentation, I just wanted to make sure everybody was feel free to contact me, and we'll spend some time outside of the presentation answering questions if we need to. So this is actually a combination of a talk that I gave at Practice Innovations a couple years ago, and also what I was going to be doing, kind of building on it at this year's Upper Cervical Experience. So again, Rob, I thank you for this opportunity because I wasn't able to get to the Upper Cervical Experience due to some weather problems. So let's just get started. I wanted to give a couple just brief commercials here, just to kind of let people know some of the things that I'm involved in and things that I just really think everyone here on this call would also, if you're not currently involved in, some things for you to. For cervical care is something I'm involved in, and we've got our annual strategic planning meeting coming up next weekend in Daytona with the board, and there's a lot of really exciting things going on there, but I don't want to spend a whole lot of time on that. I just wanted to put this up here and let people know we do have a website that's going to be coming out here in the next couple weeks that'll make joining and finding out more up-to-date information about what's going on with the council. It's not ready to go live, but my understanding is it should be any time now. But in the meantime, you can contact Molly with the ICA, and the email is just uppercervical@chiropractic.org. So moving on. The other thing is I just wanted to give a little commercial for the Upper Cervical Experience for those of you who may not be aware. In Upper Cervical Chiropractic, we obviously make up a small percentage of the profession, and we need a kind of an annual homecoming and a trade show for this facet of chiropractic care, and that's really what the Upper Cervical Experience is done. It's been a coming together of the Upper Cervical Evolution, of the Upper Cervical Fusion Conference, and Practice Innovations. They all had some really great strengths, but we wanted to put this together as a conference, a place for all of us to come together. And that annual conference is going to be in February. I don't have the dates on here, but that is the website, which will be updated in the next couple of weeks as far as the dates go on that. Some exciting things on that at the experience. The Upper Cervical Diplomate will be having their graduation at the next one. It's always going to be a place where we're presenting new research and, of course, lighting our fire with philosophy and business practices. So look into that. Again, just the Upper Cervical Diplomate, the best place, again, if you have questions about that. Of course, you can contact doctors that are taking the program. I'm one of them. Or, again, you can contact, in the meantime, Molly at or chiropractic.org. So let's get started. I want to kind of tell a little bit of my journey on how I got into this, looking at HRV and incorporating it. And Dr. Robert Brooks was and he probably doesn't know this, but was a big stepping stone for me getting into this. I'm going to briefly touch on his Taking Care of People seminar that he teaches, because it was really instrumental in me kind of asking some questions that led me into getting into HRV to help answer some of those questions. So The other thing I wanted to touch on before I move on here with Dr. Brooks is some of you all may not know, but he's having some health issues right now. So I just asked that everybody on the call, send out a special prayer, and hopefully Dr. Brooks will reach full recovery and get back, because he's a real asset to our profession and the upper cervical facet. So I'm going to share a story here in just a second on how I kind of felt like I was really on to something big, and I found out after speaking to Dr. Brooks and his 45 plus years in practice that I'd really reinvented the wheel a little bit. So that takes me into, I guess, getting started here is healing time. I'm going to talk about the context in which I've been using HRV, and I wanted to, Dr. Kessinger brought up in one of the threads some of the challenges with HRV, and the response I had is we've got to kind of look at the context of how we're using it. So what I mean by that is there's many doctors, as an example, in upper cervical that use a form of thermography, but they don't all use it in the same context that, as example, the knee chest group uses it. So we use it in context of pattern analysis to look for signs of adaptation or a pattern, a stuck physiology to help us determine how the patient's doing. But in other contexts, and some upper cervical chiropractors use thermography just as a way of occasionally monitoring their progress. So with that being said, HRV, I just wanted to kind of lay the groundwork in that I don't think from a time standpoint or a financial standpoint, it's really going to be something that we utilize on a visit-by-visit basis. It's time-consuming. It cannot be cost-effective for the patient. And I'm not really sure that the information get from it is as easy to analyze and make decisions on, as well as the thermography, which also gives us a lot of similar information about the autonomic nervous system. So I wanted to lay that down. As talking about the healing times, a question I had, I was doing some critical analysis of my own practice, and I had some questions on how I was taking care of people, and the question I had is that the care plans that I would typically put together for a patient when they started under care was traditionally a 3-month care plan, and then at the end of 3 months, the patient was supposed to transition into wellness care. And so I was asking some critical questions about that. And the question that popped up that I think I'll try and make clear through this presentation is that, people are all individual, and they come to us in a variety of different situations. So as an example, if I have a 10-year-old child that comes in that's been subluxated from birth, the effects of subluxation is going to affect them differently than somebody who's 70 years old who's also been subluxated since birth. So our expectations on healing time with those two individuals should be quite a bit different, and our care plans, in my opinion, would likely be different. So I started asking the question on, okay, well, how long is a person that starts under care, how long will it typically take for them to really reach into a point where I would say they're under wellness care at this point? So I reached out to Facebook, and I just sent some messages to some people I respected, and that would be inside Upper Cervical Chiropractic as well as outside of Upper Cervical Chiropractic. And it was really interesting. Not everybody responded or give me feedback, but those that did, the most common response is, how long is someone under care before they're under upper cervical care, was 3 months. And I just kind of shook my head at that as I was asking more questions. I was saying, this is not making sense to me. And that's kind of what I said here. Does that make any sense to you? So about this time I'm asking these questions, I was learning about this practice innovation conference that was taking place, which is an upper cervical business seminar that Dr. Jeff Schulten had taken over and was starting to run. And he had opened up a website where you could look at previous speakers' talks, and if you paid a fee for that. And so I found out about that, and I engaged in it, and I was listening to Dr. Brooks give his presentation. And all the questions that I had at this time, he was really kind of answering in this presentation. He was talking about these different phases of care that he's seen patients go through over the years, and that there were a certain amount of things that typically changed for people in the first few months. There was another series of things that happened over the next several months, and then over the next several years, depending upon how long the person had been living subluxated. So everything he was saying, I was saying, you know, he seems to be right on looking at the same thing or has thought about these things before, so I need to contact him. So I reached out to him. And this is definitely the example of where I thought I was really onto something, and after speaking to Dr. Brooks, I really found that I was really just reinventing the wheel. And this is important on how I'm using HRV. So ultimately what we find is based upon a variety of factors, the answer as far as how long someone's under care before they're under wellness care is going to be different for each person. And so the way I'm using HRV was really to monitor how the nervous system changes, how the autonomic nervous system changes as a person's going from starting care to when do they really start showing normal, healthy autonomic function on a regular basis. So some of these variety of factors that Dr. Brooks shared, and these were things that I was seeing, is, of course, I gave the example earlier about timeline, how long someone's been subluxated. You have a 10-year-old kid that's been subluxated since birth, and you have a 60-year-old person who's been subluxated for 30 years. I think reasonable expectations on timelines of that person, each person getting back to a normal balanced nervous system, or as best that person can be, the expectations are likely quite a bit different. So I've learned a lot over the last few years using HRV, and I'm going to try and share some of those examples as we go through this. So why use HRV? I wanted to give you a couple bullet points here. HRV is considered the gold standard estimate of autonomic nervous system activity. It also gives the doctor a more complete look at both sides, the sympathetic and parasympathetic sides of the autonomic nervous system. The other thing that I really found that was just really a great tool. Now, I'm not going to say every patient's going to really dive in to be excited about this, but in the conversation, when we talk about how an upper neck misalignment can affect nerves that go everywhere to the body, it can affect muscular balance throughout the body, but then ultimately we start to explain to them how it can affect their immune system and internal organ activity. I really think as we measure that and communicate that on a regular basis, that really connects some dots for the patient. So now it's just not a concept of something.
Okay, Joey, we're not hearing you now. So experiencing a little bit of audio difficulty from your side. Can you hear me?
I can hear you.
Okay, now we hear you.
How?
Okay, now continue on. Yeah, you just missed that last brief, probably 10 seconds, 15 seconds. So go ahead.
Okay. So basically, when we look at these results of this HRV, it helps open up the conversation where we can kind of explain to the patient better some of the symptoms or.
Okay, we've lost your audio.
Changes that they're noticing in their body, can really kind of connect the dots and explain to them why those are happening. I'm still here.
Yes, you're there. I got you. I hear the dog barking in the background.
Are you? Okay. 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 Okay.
You're all good.
Is that dog pretty loud?
No.
Okay. All right. Well, I'll move on. The last
bird gives us.
And Rob just.
You're sitting out on your back porch having a great time, so that's awesome. Go ahead.
Okay. All right. So the last bullet point I want to get to is really adaptability, and you all may be familiar, but the Diplomate in Philosophy last year opened up a weekend to allow doctors to come to their adaptability symposium, and I went to that to really kind of hear some of the leaders in HRV outside of the profession present, and just everybody was talking about this concept of adaptability, which is really our foundation in chiropractic. So we look at that when we do our pattern analysis and patient care, and HRV is no different. When we're looking at HRV and results, we're really looking at how well the body's adapting through the sympathetic and parasympathetic balance and a variety of other measurements. So that's all I had here. Is health is really all about adaptability. Health is optimal adaptability. So, again, I'm just kind of reviewing things that everybody knows here, but just to make clear where we're going, chiropractic's not looking to label things, but we're looking to the spine for the presence of interference to the system that regulates how well our body's able to heal and adapt. So with that in mind, I think the results make more sense. And that's the type of conversations that I have with patients as well, is to let them know that's what we're looking for. We're measuring the system that ultimately controls how well the body heals and adapts. Well, the system that I use, although I think it's a great system, I don't think it's obviously absolutely necessary that you utilize this system to do HRV, but I want to just briefly touch on some of the screenshots you'll see and what it is. It's made by a company called LD Technology, and that's a company that primarily sells to the medical profession. But the way that I found out about this technology was Dr. Cyril Rustici, who's a Blair doctor out in Kansas City, started utilizing this technology, and as it was coming out, and he actually won in 2007 the best presentation, and this was in front of a group of doctors from all different professions. And so Tom Forrest has sent out an email way back in 2007 about that, 2008, and at one time you could watch it, but that really got me interested and started asking questions, but it took several years before I really bit the bullet and decided to jump on the HRV bandwagon and start using it. So again, I won't spend a whole lot of time on this, but I just wanted to, these are some screenshots of the technology. It does a lot more than just the HRV, but I'm only going to really try and address the HRV tonight. It's nice to have more information because it allows you I think the more things we measure with the patient, the better rounded we can understand the changes that they're going through and explain those things to them as well. So goal setting, and when we're looking at patient healing times and care plans and expectations through HRV or other outcome assessments, is Jim Rohn uses a quote that he talks about what he looks for success is to make sure that you're making measurable improvement within a reasonable amount of time. And I really kind of stress that to the patients because all patients come to us with different problems that have many times been there for different timelines. Dr. Brooks talks about, and these are some things I also share with patients, and I'll share this in the presentation, is when I'm analyzing someone's films and their exam findings, the things I'm looking for is how complex of a problem are we dealing with, approximately how long has it been this way, and then ultimately as I go through my first adjustment and my analysis is how well can I correct this problem. And then over time we're going to look at how stable it can get, but then we want to give reasonable timelines on when we should see things change. And prior to doing HRV, I was just able to use other doctors who've been in practice longer than I had information and kind of say these are things we've seen. And then so HRV has given me some insight to some of those, and I'm going to try and share that. But as we go through this, we want specific goals that are measurable, but again obtainable, that they're relevant to their care and also time bound. So I'm going to talk about that here. Just to understand our protocol and again understand the context and some of the measurements that we're looking at, is I'm not utilizing HRV on a visit by visit. We do it on the first patient appointment on the new patient exam after we've determined that this patient is a candidate for upper cervical care, basically meaning they have an upper cervical subluxation. Then I perform an HRV as part of that initial exam. And also just to touch on for those who aren't familiar, I don't have to do the exam. The exam's relatively simple to set the patient up and to perform, but we train our staff to do that, so it's not something that takes time out of my day, but the results are really important for the care. Okay, I do my first follow-up about 2.5 months into care, so usually about 10 weeks into care, and that's give or take. There's some things that you'll see in some of the exams. That's our goal when we're planning to do it, and life happens sometimes, and sometimes it's a little beyond that, but that's our goal for the patient when we start. When I talk about phase 1 of care, this is some of the stuff I felt I was really reinventing the wheel after speaking to Dr. Brooks. He talked about the first phase of care is going to last about 12 weeks, and I'll just share some things that I was noticing, and then Dr. Brooks, as I was explaining it to him, he was just shaking his head and somewhat giggling a little bit on again that he'd seen these things for years. So commonly in the first phase of care, the spine starts to free up, symptoms start to improve. Many people start to notice their spine may start to shift or pop as things start to unlock. But there's some people will start to hold their alignment right away. Others take more time, and that can be based upon complexity. But I'm going to do my reevaluation at the end of that first 12 weeks, and I do my HRV just prior to that, because what I'll do is we'll do the HRV, I'll go over the results, and then the last visit is when I do my reeval on how they did in phase 1. The second phase of care is a 6 to 8 month period of time. What we typically see in this phase of care is this is when most people begin to stabilize or hold their alignment for weeks or even months at a time. Of course, some people start that in phase 1, and of course there's the other spectrum. Some people even have a challenging time doing that in phase 2, but the majority of people tend to hit a stride in phase 2 where they start to hold their alignment on a more consistent basis. I'll do a third HRV, which is their second follow-up, halfway through phase 2. And I'll do another one at the end of phase 2. Phase 3 is the recovery process. This is during this phase, the example I used for patients is when we're talking about reasonable healing times or reasonable expectations. The example I use is if you had a broken arm, we could set the bone and cast it, okay, and now we fix the problem. But now it's going to take a reasonable timeline for that to heal, and if you understand it may take 6 to 8 weeks for that to heal, then you have reasonable expectations. If you think it's going to heal overnight, then that's not reasonable. So with the spine, and when it's been subluxated and you've been living subluxated for a period of time, I want the patient to understand reasonable changes, and HRV is able to give us an insight watching the healing process a little bit and helping explain what's taking place in them. So phase 3, now they're typically holding their alignment consistently for weeks or months, and I usually do their HRV evaluations on 6-month intervals until we see consistent, normal, great-looking scans on a regular basis, in which case many people will just do it once a year at that point. Is kind of where we're at. So that goes on a case-by-case basis, but that's kind of the context of some of the results you'll see. This is a setup in our office. Again, the technology does more than HRV, but a big portion of the exam, of course, major thing I'm looking at is HRV, but that's the setup. So let's get into HRV. It really is a big subject. I'm going to try and give some of the details, but I don't want you to get caught up in it too much, because if we can understand the complexity and then back up and look at some of the simplicity, some of the things I think are most relevant to us and helping us explain what's going on to patients. So HRV is the mathematical analysis of time between heartbeats. HRV also provides indicators of autonomic nervous system activity, and again, it's considered the gold standard. So it's broken. HRV really can be broken into two analysis. There's a time domain, and then there's a frequency domain. And I think as you understand both of those, and I'll be honest, I'm still learning a good bit about these, but there's some big ones that I look at on here. And as we learn what they mean and what they indicate, it allows us to really understand how people are responding under our care. So the big one on this screen that I'll talk about is the SDNN, because I will reference that. That's the standard deviation between your normal to normal heartbeats, basically. You can also look at the R to R intervals. On my technology, it tends to want to reference more the SDNN, but these are very similar measurements to my understanding, and everything I've looked at seems to indicate that they're basically telling us similar information. So that is essentially the variability. The higher rates of deviation, higher rates of the standard deviation indicates higher variability. And I'll reference that a little bit as with increased variability indicates increased adaptability. Low ranges of variability indicate low ability to adapt and actually puts the patient at more risk for more catastrophic events. So, and I'm going to share some of the research with that as well. The frequency domain is one that I think is really helpful for us. There's a total power that really I haven't looked at a whole lot. I started looking at it after Dr. Kessinger came and presented at the Upper Cervical Diplomate, And as he was sharing the things that his group's been doing, it really kind of connected some dots for me and gave me some insight on things I should look at. So I have started looking at the total power of the autonomic nervous system, and as that increases, that indicates increased activity of the nervous system, and that's usually a good thing. The very low frequency is poorly understood, to my understanding. In the literature, there's some indications that it may indicate some emotional stress, so it's not something I look at a whole lot, or have looked at a whole lot, and I may with more time. But the big ones I look at, I've kind of made a little bold here. They didn't stand out as much, but the total power, the low frequency, is more of a sympathetic measurement, and I'm going to show again some results here in a minute, but if you'll just kind of make note that low frequency is sympathetic, high frequency is parasympathetic. And again, if you really look into this, low frequency actually looks a little bit at both, but it's more of a sympathetic measurement, and high frequency is really one of the best measurements we have to look at parasympathetic. We'll also look at the ratios between sympathetic and parasympathetic as well. So again, not to get too technical, but looking at the HRV breakdown, there's some early activity that's the very low frequency, then the mid is the low frequency, and the high frequency is the later information. This is just another little chart. I know it's a little blurry, but the top part's just showing again the high frequency is more of a parasympathetic measurement. The low frequency is more of a sympathetic. And as they come together, that's where we get the HRV pattern. And the technology separates that out for us and is able to give us some breakdown of that information. Okay, so looking at the autonomic nervous system, of course, you know, this is our bread and butter, but I really wanted to, I've seen some different things take place with people, and some of it I think is anatomical, and I just wanted to point out a couple of those, because again, some of this may be just the way that, you know, this is my hypothesis, my interpretation of it, and we may find out that's not the case, or we might find out it is the case, but this is one of the things I'll explain to patients. Is as we break down, take a closer look, you know, the big green nerve that branches off the brainstem, of course, is the vagus nerve, and I'm going to show another view here, but as it passes through the base of the skull, it runs anatomically just anterior to the atlas and the rest of the cervical spine. So Dr. Daniel Walters there on Facebook had a great picture, and I just snagged it here and took a freeze frame just to kind of show. I thought it was great. I've used it actually a little bit in for patient-reported findings, but as the atlas subluxates, the transverse process can start to put pressure on the jugular vein, the vagus nerve, and can also affect the carotid artery. Now, we've seen this in the blood pressure, Dick Holt's blood pressure study talked about some of these mechanisms. The MS research out of Italy that was done is also talking about this, and Scott Rosa, and his work that he's doing with the upright MRI, he's been just an excellent asset to the Upper Cervical Diplomate program, and he's been able to show us how to pick up on this on MRIs from several views. And so this is a mechanism. There's mechanical irritation of these structures with some people, and maybe more than we know, but that may be part of the imbalance to the autonomic nervous system. Also, another portion is obviously stress or tension on the brainstem being the control center for the autonomics as well. But I just wanted to point that out before we moved on as well. You know, I had this thought. This was something that was kind of running through my mind as I was putting this together, because I remember thinking, you know, what if we had a tool that would help us prevent patients from leaving care before they had recovered, you know, to allow them to know that we've made some great progress, but where are we at? And the wording on this wasn't exactly what I was going for here, because I want patients to choose that this is something that they want to do, but I want to make sure that I'm giving them enough information so that they're able to make the best educated, best choice for themselves. And with the phases of care that I talk about, as well as the HRV, it gives me a great way of saying, and I'm going to show a great case of this here in just a minute. As people progress, you know, life happens. Sometimes they're not able to continue care. So we always open arms, welcome them back, and when we do, we can do a reevaluation and see how much progress they made. And when we do a reevaluation, see how much do they lose. And HRV has been really helpful in that because, again, it's not me kind of telling them that they've lost this it's objective measurements here that just show them really here's good things that were happening, and of course when you don't take care of your spine, they can progressively get worse. Okay, guys, this is one of the screenshots. I'm not going to spend a good bit of time on that. I've got several more I want to go through. Again, this can be very technical. The top portion of this is the time domains, and the bottom portion is the frequency domains. I'm going to spend a little bit of time on this, but I just wanted to kind of touch on, this is not very patient-friendly, so I wouldn't spend a lot of time with this on a patient, but there's some things that we can look at as doctors and kind of look, again, for the standard deviation as well as the R to R intervals, and are able to look at the balance between the sympathetic and parasympathetic. There's another way I go over this with patients, but depending upon these just research purposes, research this data can be really valuable.
Hey Joey.
Having on the
Hey Joey. Hey Joey.
Yes, sir.
On the very last part,
yes.
Right after you got past, you talked about the power LF and the HF. And then for about 20 seconds, we just kind of lost audio, and you were saying something that sounded pretty important. So, sorry. No, you're already on that slide. You were on this slide,
on here,
and you were just talking about how the R to R intervals. You could see that, and the SDNN, you could see that, and then you started talking about the bottom portion here, and we lost you.
Okay. Thanks, Rob. Basically, I was just addressing, and I'm going to go over this again in a few more, quite a few more here if we have time. Just looking at, I'll look at the low frequency measurement as a sympathetic again, and the high frequency, and I'll look at the balance. But again, on this screenshot that I'm showing you here, I don't think it's terribly patient friendly, but I think it is valuable for us while doing research. Either that being case studies or other research with this type of data. So some of these, I guess the information I'm going into, just to clarify, I wouldn't spend a lot of time obviously going over it with patients, but I do want to give them the big picture. I'm going to go over, guys, what I did here is that I tried not to cherry pick cases here. I wanted to just randomly go through and grab some and then just talk through it and show some things. This one was one that I presented in Practice Innovation. And what I want to talk about, there's a lot of data on here. And of course, I'm not going to go over all this. I wouldn't go over all this with a patient. Just to orient you a little bit, this central portion here, the cardiovascular score, that's for patient education. It's not really clinical data. I mean, it's very similar to if you're using the Titron. We get our clinical data from the graph, but if you pull up the bar graphs, I think that can be good patient education, and that's very similar to what this is here. So as we go through it tonight, I probably won't spend a whole lot of time on it, but you'll see that it, just so you understand a little bit, everything's color-coded, so dark green is going to be the best scores you can get, light green are good scores, gray are normal. So anything gray and green on this system are indicating good scores. Yellow are warning signs, orange are low, and red are considered poor scores. The outer numbers, green means they fell within normal range, yellow indicates they're higher than normal range, and blue indicates lower than normal range. Okay? Again, we'll look at everything in context of what's taking place with the patient to kind of better understand those. The big ones I'm going to look at, though, is I'm going to look at the SDNN. That's ones I'd like you to look at. And also look at I think if we just look at low power, we may some of these, but I think it's changes for creating CNN is a variability indicator. Higher variability indicates higher ranges of adaptability, and low frequency is a sympathetic, high frequency is a parasympathetic. Okay. I'm going to assume at this point that many people understand that being in a sympathetic dominant state is not a good thing, and that more parasympathetic is more protective, and balance over time would really be good. We want these two guys to play together, But when the parasympathetic nerves are more active, that's more protective, more indication of more healing, along with higher variability. So this person's pretty sick. It's a 40-year-old male who came in, and this was December of 2012. This is April of 2013, so his variability kicked up significantly. Now his sympathetics came down quite a bit. His parasympathetics kicked up quite a bit. Okay, I'd still like to see this one drop a little bit more from what I'm seeing, but that's a really huge change. It was just a great thing. Of course, symptomatically, he'd responded really well, but just backing up, you know, even if you look at the middle portion, it was a good visual for the patient. Really helped him understand the value of what we're taking care of here. Now, that's just more of the introduction. I want to get into some other cases. This was actually his wife, by the way. His wife had low variability, was also in sympathetic dominance, and when we did her exam, now I talk about different factors. He actually had a more complex misalignment. His case, he had been subluxated for a longer period of time, and I think that really tells the tale, and I'm going to show you several others, is people who've been subluxated for longer periods of time, I don't see them go to a balanced state where the sympathetics are normal but calmer than the parasympathetics as quickly as somebody who has not been subluxated as long. And another case I'm going to show you, and a big factor, of course, is our ability to actually correct the subluxation and get it stable. And this is actually a follow-up of hers later. So let me back up a little bit. I know I flew through that. Variability, sympathetic, parasympathetic, all improved here after the first few months of care. Now her variability dropped a little bit, but we were still seeing balance, and we were seeing a lot of other improvements. And that's kind of one of the things I'll stress as we go through this is, and I tell patients, again, is we're looking at the whole picture here. So there's going to be times when their nervous system's working hard, and then some of these scores won't look all that great, but really if you ask the patient, they're doing fantastic, okay, which is cool. We just need to give it time and watch these, and as we start to see more of that balance take place, what that helps me have confidence doing is letting the patient know that their body's really going through a healing process, and now they're actually reaching their recovery rather than just giving symptomatic relief, because of course we know that when we correct the upper cervical spine, is many people feel better a lot quicker than their body actually becomes healthier, and I think HRV gives us some great insight to that. This is more for patient education. These bar graphs over here, some of them are extrapolated from the data, but the top portion are actually the low frequency, high frequency. This is a nice thing for just this technology is they have a color coding here where if the organ systems show up gray, these bar graphs will be green. This is basically the model over here is a educational model based upon these measurements. So you've got underactivity, which is blue. You've got overactivity, which is yellow, and then you've got normal activity. So this is also that lady, and it was great to see, you know, for her to be able to see these changes, and this is their next follow-up. So and see that she's sustaining those changes. Okay, this is a case study that I've been working on for the Diplomate program through the upper cervical, and I wanted to share this with you all. I presented this at the Diplomate because it was really interesting. I thought it was interesting. Not only was it asthma, which you know is not a neck issue, obviously, or maybe it is a neck issue, but I wanted to show you some of the challenges I had with this little guy. He's an 8-year-old male. I don't have the whole history. I don't want to spend too much time going through this because I would like to get through a few more of these so y'all can see a little more. But the biggest thing I wanted to tell you, and the reason why I'm sharing this one, is he had a tough neck for me to adjust. I had a hard time getting him clear, and I had a hard time getting him to hold for the first several months. So on his first evaluation, which is what you're looking at here, his heart rate variability score, he had good variability, and he really should. He's 8 years old, but he was in a more sympathetic dominant state. And after a few months of care, which, again, I was, as an 8-year-old, I don't check 8-year-olds, you know, multiple times a week. Even, you know, a lot of times I'll start off checking them once a week, occasionally twice a week until I start to see them stable. But due to a variety of reasons, we weren't able to, and I was just adjusting him on more often than I typically see, and the results of this will show this. We'll show that when we're not getting the subluxation corrected, there's really not as much change and improvement that we'd like to see. I'm going to show you this screen again, but the next slide, the reason I put this in here, this is another screen that you can go to in the software. I know it was similar to the one that Dr. Kessinger showed with his software that has these basically 9 blocks. There's two upper quadrants. There's basically, you can see it better here in the center. There's a light blue, a gray, and a light blue. So the gray center is basically indicating normal sympathetic, normal parasympathetic. I'm going to show you a interpretation chart. That's basically what this is. So based upon wherever this bullseye fell, it's kind of a chart here where we can quick and easily better understand what's going on with that person. So this kid was into a normal parasympathetic but high sympathetic state. You'll see that here on his bar graphs. Again, I know these are kind of busy, but just another way of looking at it. And again, I had a hard time getting his upper neck corrected. So this is his follow-up after a few months of not holding well, not clearing out well. I got some more parasympathetic activity. Maybe I'm stimulating the parasympathetics by just hitting him in the neck when he comes in, but I wasn't getting good clear-outs, and he wasn't holding well. And he stayed in a sympathetic dominant state. Symptomatically, there were some minor changes, but nothing significant. He was still having to use his inhaler and was still having trouble when he would go outside. It did change. He went to both high sympathetic, high parasympathetic, and again, you'll see more orange bars, more activity here as well. Then we finally get the listing right. He starts holding, he starts clearing out. We're not adjusting near as often. Symptomatically, he really starts to improve. He's getting off his inhaler at this point. He's not having problems playing outside. His variability dipped a little bit, but it's still within normal range. The sympathetics calmed down significantly, and his parasympathetics are staying. Now, again, he was 8, turning 9 at this point, so he gets back to a more balanced state relatively quick, where I'm going to show you some adults that that just isn't the case. It doesn't happen that quick in my experience. And that's his balance. Both were normal. And again, you see all the green bars, everything's starting to balance out. So age, complexity of misalignment, our ability to correct it, all these are huge factors in how people are going to respond. And again, we all know this, but looking at these measurements, we can really see it. Rob, how am I doing on time right now?
I think you're doing really well. It's 7:45, so I think.
Okay, good.
If you can, yeah, you're doing good. Great presentation. Keep it going.
Okay. So this patient had, I want to give a couple different scenarios over these next few, and I really think I'll tie it up in the next 10, 15 minutes. This person, when started care, their nervous system from an ANS standpoint was in a balanced state, and I'm going to show you that. So, I learned this from Dr. Brooks as well as others, but subluxation affects people differently. Some people it affects them more structurally. Some people it's more maybe sensory, and some people it may be more neurologically from a standpoint of the autonomic nervous system. I still think it's valuable to be able to monitor that and tell people that, and it really correlates well with their symptoms as well. So when they come in and they're telling you these are their issues, I don't remember exactly with this patient, but more than likely I wasn't surprised to see not a lot of autonomic dysfunction because their case history didn't represent that. So I will apologize. These next several are going to be blurry. The way I had to cut and paste this, we lost a little bit of quality, but you'll still be able to see the overall numbers of the standard deviation, the variability score, the low frequency, and the high frequency. So this is someone that was subluxated when they came in. But these were the exams that we found. I do remember her now, about looking at her name, that she had a lot of structural issues in the lower back and upper back. This is after a little over 3 months of care. Her variability kicked up significantly. Now, she's 55 years old. I didn't have how long I believe she's been subluxated on here. But anyways, her variability kicked up significantly, and she went into a more parasympathetic dominant state, which is more of a protective and healing state. So that was a good sign. A few months, about 4 months later, we did another exam, continued with her higher rates of variability, and more still on a parasympathetic dominant state. Now this one was kind of interesting. So same lady, a few months later. Now look at this. Her variability stayed up, but she kind of kicked up, and her total power went up significantly, by the way. And so her body was really working. It was going through their cycles of healing. So many times when people are going through these changes, when we do an HRV around that time, it just really shows, yeah, that's what's happening. And so I didn't freak out when we saw this. There was other good things that were taking place. We just wanted to explain, okay, this is what appears to be taking place in your body right now. We want to watch that. I don't want it to stay in that state, so we'll do another follow-up and see how that goes. And sorry, again, that's blurry, but that was back in September. And again, staying in a good, still parasympathetic state. Now, again, she's 57 at this point. I don't have her x-rays on here, but it's very likely, from memory, that she was probably subluxated for at least a few decades. So coming back to the beginning of this presentation, I was talking about reasonable timelines for healing. It's just not reasonable. Looking back, the way I used to think is that after 3 months she should be on wellness care. She wasn't well yet. She's still not well, in my opinion. She's still going through a healing process. She's still making changes. And so I don't need to tell her she's well until she's actually well. And this is a way for us to monitor that. All right, this next case here. This was really interesting. It's really somewhat sad. Good news is nothing catastrophic happened, but I want to share this. There's a lot of research out there, actually, if you just Google this, Google the autonomic nervous system and sudden cardiac death. There's been several studies that talk about this. What this study talked about here was that during the last 2 decades, this was published, if I remember correctly, it was in the early 90s, but you can pull that up online. But in the last 2 decades, compelling evidence has been provided for the existence of a tight relationship between the autonomic nervous system and sudden cardiac death. Specifically, sympathetic hyperactivity favors the onset of life-threatening cardiac arrhythmias, whereas vagal, parasympathetic activity exerts protective and anti-fibrillatory effects. Okay, and then they go on to talk about looking at the autonomic nervous system will likely be a good way of helping people determine if they're at risk of cardiovascular disease. What's better than that is, guys, what we're doing with the type of care that we're providing is we're changing this for people. And that's what I want to show you. This gentleman, when he started care, 62 years old, this was back in 2012. Variability is within normal range, but still, I typically tell people what I've seen with most people, when they get to a good healthy state, I see it stay in the 50s and 60s, in some cases 70s. So, he's not way off that, but he did have a lot of sympathetic activity, and based upon the research, we don't want that. That's not protective. That's putting him at higher risk. So, honestly, probably at this time in 2012, I didn't have a good understanding, so I probably didn't paint that picture as well as I should have. We did a follow-up a little while later. His variability, again, came down a little bit, but we're starting to see more balance take place between the sympathetic and parasympathetic. Still in a more sympathetic state. It's on the high end compared to the parasympathetics, but definitely a good change in the right direction. Our next follow-up with this gentleman, we're starting to see the variability kick back up, and these are common trends that I'll see, is we might see certain things dip a little bit while other aspects of the nervous system are changing. And these stay pretty consistent. Now, of course, I went through those pretty quick, but you look at other aspects of his cardiovascular system, you start to see the changes that take place from the first to the second, again, first to second, and then from the second to third. We're really starting to see a lot better improvement in how his body's functioning. Now, here's the bad part. That's not even, yeah, that's the bad part. So he quit care for whatever reason, and took some time off. And so what happens when people don't take care of their spine and they don't hold their alignment is they go back out of alignment, their body starts to regress, not only from a structural standpoint, but from a physiological standpoint. So he came back in, and what had happened? He'd gone back into a sympathetic dominant state. And I took this at the beginning of April. Docs, he had a heart attack a couple weeks ago. Now, thankfully, he's fine. as far as he survived. It wasn't a catastrophic. He didn't die from it. But what does the medical profession do for arrhythmias? Is they give beta blockers, and what do beta blockers do is they decrease sympathetic activity. So they're on the right track. They're trying to do what to a certain degree needs to be done. So what I'm in the process of doing is writing a report to share with this cardiologist some of the progress that this gentleman had been making. And if we'd have just continued on the process, we likely, potentially, I'll choose my words better, potentially could have avoided this situation. But I definitely think it's absolutely critical, and I stressed this to him and his wife when they were in the office, that this is why it's happening, guys. It's not a lack of beta blockers. It's physiologically, his body was in a state of sympathetic dominance, and when you're in a sympathetic dominant state, you're at higher risk for cardiovascular issues and sudden cardiac death. So, of course, this is just at the beginning of April. I haven't done the next follow-up, but I have no doubt, based upon the trends of what we've seen in the past, that we should see these same things happen and really help this guy recover and get to a point where he's able to get off the beta blockers in the future. This was one of the trends, another screen from the technology. Unfortunately, when they updated the software, I lost a few of his previous scans, but these basically line graphs. The low frequency, the blue line is the sympathetics, the red line's the parasympathetics. This was just his graph that, if you really look at the one when he began, it was higher than this, and they just gradually were coming down. He quit care, and what's happening, he's gradually going out of balance again. And so it'll be a good way of showing him that, again, taking care of his spine can really help his overall health. Last couple, guys, and I think I'll be finished. This was a very complicated neck. As y'all can look at it, this lady has been subluxated for a really long time. She's got ligament damage throughout the cervical spine. She's had multiple injuries, but a very complicated neck. So we got to take in mind when we're looking at what are some reasonable expectations for this lady. I do not expect, if her autonomics are out of balance, for that to all get better in 3 months, or likely even 6 months. But we should see measurable improvement in those timelines. And she's really had a great response symptomatically, but I want to share her scans with you. Now, this is that heart rate variability in the upper left. You'll see with this lady, now again, she had a bad neck, so I want to point out that, by the way, when people have a really bad spine and they've been injured for a long time, I commonly see sympathetics jump up for a little while. Now, I see other improvements take place, but I'll see this sympathetics jump up with people. It seems like when they're going through a lot of structural changes, I don't know if part of my thought is that because we've got the sympathetic chain off the spine, if that's changing, maybe there's an increase in sympathetic activity. Because I don't see this in healthier individuals, they'll typically get to a more parasympathetic dominant state quicker. And what I mean by that is, when I say a healthier individual, somebody who doesn't have as many injuries in the spine, who stabilizes, holds their alignment well. I tried to give some good example of that. Hopefully I'll get to it, but I just want to show that, again, with time, you look at this. This was September of 2013, and it wasn't until March of 15 that we really saw her jump down to a more balanced state. Now, was she in a balanced state in between here? It's likely that she was, but when we do these exams, I'm wanting to see what happens on a regular basis. There are some consideration we have to take when doing these exams. There's a lot of factors that can affect the sympathetic system. So just like with thermography, you don't want someone to be sweaty when you're doing a thermographic scan. You don't want them to be anxious, or if they just got in a fight with their spouse before they right when they walked in. Those things can affect the results of the thermographic scan. So you got to take these things into consideration with the HRV. And one of the things I've found out is when I do these follow-up exams, I was going to put this example in here, and I think it was one of them that I had to delete, Rob, but I try and not do these follow-up exams on days when they get adjusted. I try and do them on days when they come in and they're holding.
Right.
If I do them on a day they get adjusted, it seems like everything is haywire. And the only thing I can attribute to that, and that doesn't mean like it's all bad, it's just different. It doesn't make sense with the other trends that I've seen. And so I'll usually look at the results and I'm like, what is going on? And then I'll look back at their their travel card or their visit, and I was like, I adjusted them on that visit. So it's something I was kind of playing with, and now my protocol moving forward is I'm just not going to do a progress exam on a day they get adjusted. I'll wait for a day for them to be holding. Okay. These are some of her scans. Again, it just correlates with this. You'll see good variability, decent variability within normal range, a little bit more sympathetic dominant than parasympathetic. Now, these things get a little worse. She got into a more sympathetic dominant state. But the reason I wanted to put this one in here as I was going through it is symptomatically she was noticing like really significant changes in her mobility and the way she was feeling. And so, you know, I look at this and I was like, okay, I don't like any of that, but this is what was happening. Okay, so we said, all right, well, this is where you're at. Your body's changing a lot. You had a really damaged spine. So we did another follow-up. We're starting to see the variability increase. We're starting to see the sympathetics come down again. Then we continued to see the variability increase. Then we saw more power where just both of them were working hard. And then finally, look, we see her variability I still would like to see improve, but it's staying higher than it was when we started, and we're starting to see some balance there. So some really good changes. This is just another example that everybody's different. I've seen some ups and downs with people here. This person had a lot of, she's actually not under care anymore, which stresses me because I don't think she's in good shape until not taking care of her spine here. But I think she's really at high risk of a bad thing happening if she doesn't take care of her body. So that's her first exam. The follow-up, we're starting to see, again, some good changes, variability. That variability continued to go up while her both systems were working hard. It dipped down again and then jumped back up. And you'll see these trends with people as well. And I think a lot of it has to do with different cycles of repair, a variety of different things that happen as people are healing. All right, so that was I guess my point is sometimes we just got to stick with the care. Look at everything. So I wish HRV, I wish you could just, I could tell you guys that just do it and you're going to see these things happen. But again, you got to look at the complexity of misalignment. How long have they been subluxated? How well are they getting corrected? How well are they holding? What are some other lifestyle factors, again, that may be impacting their healing process? And then you got to look at all those things. So just because the HRV may be going through some changes, I'll watch it. If I continue to see bad trends, then, which guys, I can just tell you that that's not something I've really seen, is because the care that we do, the body heals. If we're getting good quality upper neck corrections, you'll usually see them break out of some bad patterns here. So this was just another example of another. This was a male, 60-year-old male. Not a terribly out of balance system, but more on a sympathetic state slightly. But then it went higher sympathetic and low variability. Then it came back, stayed this way a little bit, and he finally started to turn the corner. And again, symptomatically, he went through some tough times there, but is really the long-term sticking with the program has really got him into the healthiest state he's been. And that is it. Okay, so I had to cut some stuff out, but I'll be open to any questions if anyone has any.
Okay, so I'll get on here and I'm going to look on here and see. We do have, let's see, I can't see it here. All right. I do have a number of questions, so let me just see if I can get to them. Okay, so everybody has a little pain in your where you have where you can hold your hand up, I believe, and we will. I've got Kevin here. Is Kevin? Are you there right now?
Yes.
Okay, so do you have a pane on there or something, a window that you can raise your hand?
I do.
Okay, so if anybody has a question, raise your hand because that would be the way that I would be able to see whether you have a question, and then I can open it up for, okay, this is Dr. Craig York, and we will let folks from Arkansas in the group, so okay, here we go. That was a joke, but I didn't know that. Uh-oh. Maybe we won't. Okay, so for whatever reason, I'm not able to click on to Craig York, so I'm going to try back in just a little bit. I'm looking for other hands. Okay, I feel like an auctioneer.
Doc, do you mind if I ask a question while you look that up?
Sure, yes, go right ahead.
Dr. Miles, what is your 30-second, explanation to patients? How do you just kind of talk to them in layman's terms about the HRV?
So I basically talk about, I'll use that actually, depending upon the case, that study that talks about sympathetic hyperactivity. Sometimes I'll use that, but I use that chart, obviously the autonomic nervous system chart, and I'll just explain to them briefly that the sympathetics are basically your fight or flight nerves, and I want them healthy in case you need them, but generally speaking, if you're not in a fight or flight situation, then they typically cause more problems than good. So, in my neck of the woods, I can use the example. We got some mountain men here in the Carolina mountains. So I'll use the example. I tell people, if you're in the woods being chased by a wild animal, you need those sympathetic nerves to kick in so that your brain can rush blood to your muscles and your eyes will dilate, and so that you can do everything possible to survive the situation. But once you get away and you survive the situation, you want those sympathetic nerves to calm down. And the parasympathetic nerves are more your rest, your digestion, your recovery, your healing, your protective nerves. So generally speaking, what I'll tell them is I want to look at the balance between those. And basically, so I'll talk about, we know from the exams that this upper neck misalignment is affecting the nerves that control muscles throughout your body. And I'll talk about, whether it's a postural analysis, leg check. We've seen it affecting the nerves at the base of the brain through these temperature scans. And then this final piece of the puzzle really gives me a good idea if your body's staying in more of a healing state, which it needs to be in, or if it's more in a survival state. Now, in that technology, there's more detailed exams I can look at, which I didn't really have time to go over in this presentation. But that's kind of I just stick with the fight or flight versus healing. And sometimes I'll refer to the sympathetics as the gas and the brakes a little bit, of course, and I think that can be helpful in certain situations. So some of it depends upon what's going on with the patient. If this patient has anxiety, has kind of a short fuse, their wheels are always turning, I can really explain, okay, with what you're experiencing, and the exam's indicating it, correlated and showed that, that you've got these sympathetic nerves that are overworking. And then I'll show them from a structural standpoint, even on their x-rays. You can see how on here we were measured that this top bone is in a twisted position, and then, I'll pick up a model or show them, this is where the nerve passes through, and then as the anatomy gets in an abnormal position, it can put stress on those, and that's why this imbalance is there. And again, I know that was a lot longer than 30 seconds, but that's kind of the gist of it.
I think that's good, and I would also like to add that that patient that you shared, which was fantastic, about the one that had the excuse me, it had the heart attack, and there's also evidence, and you may have alluded to this, but there's also strong evidence in the literature that shows that the stronger your heart rate variability is, the better you are able to survive a heart attack. So it goes both ways. And so, with the care that you provided that he had under his belt, it probably did or it could have quite possibly saved his life, even though he did have the heart attack. So sometimes, and I thought you brought that out really well, sometimes we don't even know what kind of good we're providing for patients. And this kind of tool like this gives us really great information for ourselves as well as share the patient. So, okay, Dr. Miles, do you have any parting words?
I don't, other than, everybody, well, I guess I do. If you're not part of the Upper Cervical Council, guys, I just urge you all to really consider. It's so the cost is ridiculously cheap. Really, if you break it down, I think it's like $15 or $18 a month. But it'll keep you. The council's working on really making sure that we keep doctors engaged and things that we're doing to help the profession, and we want you all to be involved. And there's elections every year with new doctors. So, guys, the way I got on the board was I just threw my hat in the mix and said I want to be involved and I want to help. So I just urge, join the council. And get involved, and really consider taking the diplomate. It's a big undertaking, but of course, Dr. Kessler, you came and gave a talk, and the caliber of the students that we have there. Just a great just a great experience. I mean, if you can imagine going to chiropractic school and everybody was an upper cervical chiropractor, that's what you're going through when you go through this diplomate program. It's just everybody's got different views, different ways of looking at things, but you're all on the same team working towards the same objective. So that's kind of my last parting words.
Okay, well, I would say that, yeah, I had a great time up there at with the presentation I did up there. We did the neurology session. It was really awesome being around, because I have to say that this is really an elite group of folks. And anytime you put yourself in the midst of doing a diplomate like that, you really are going to be a cut above in your information. And you can see how Dr. Miles presented that, very professional. You can see he has a lot of competence and a lot of confidence, and I thought you did an excellent job. One other thing I would add for you, Dr. Miles, is if you will put up a form on the Facebook page, which is an application for the council that somebody could download. Can you do that, or can somebody else do that? We can have somebody do that.
Yes, absolutely.
You know what I'm talking about, where somebody can just look at it, download it, and because sometimes people don't do things because I'm getting ready to do it, and then it's you got that extra step and all that. So let's go ahead and do that. And fantastic. I mean, just a fantastic presentation. I'm going to put the recording up by tomorrow. I'll post it up on the Facebook page, and I think that would be an excellent place once that thread comes up for questions. And if Dr. Miles, if you don't mind answering questions as we go through that, we'll post it on that thread, okay?
Absolutely.
All right. Thank you very much, and thank you, everybody, for attending. That's a great, great, great presentation.